Are you ready?
Yeah.
Got your water and all that?
Oh, yeah.
Okay. I'm going to get some real quick. All right. Well, here we go.
Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I am with Jeff, an ER physician and EMS director. Hey, Jeff, how you doing?
Great. Thanks for having me on here.
If you would you please tell us a little bit about yourself?
Yeah. So my name is Jeff Siegler. I am a academic emergency medicine and EMS physician at Washington University in St. Louis. I am a former paramedic as well before medical school. And now I work primarily out of the hospital with different EMS agencies, both in the general EMS 911 side, as well as doing some tactical and other special operation medicine. And then I do still work in the emergency room occasionally. And then I am also the liaison from the National Association of EMS Physicians to Special Operation Medical Association.
Outstanding. So today I'd like to go over some ventilation strategies, and specifically you wrote a paper about using the pediatric BVM on adult patients, and I'd like to go over that as far as the good and the bad about it. So in your paper, you talk about low tidal volume strategies, and it kind of centers around ARDSNet. So just so we can get a quick background on it, ARDSNet, who exactly is that strategy targeting? What type of patient is that strategy targeting?
So the ARDSNet came out of a 3-year study back in the late 90s where they took ICU patients that had already been intubated, already on a ventilator, and were showing significant lung damage from whatever reason, whether it was their primary disease or the ventilator. And they split them into 2 groups where they said, okay, this group is going to get kind of standard of care, which is a tidal volume of 12 milliliters per kilogram of ideal body weight. And this other group, the intervention group, is going to get 6 milliliters per kilogram of ideal body weight. And they did some other stuff with PEEP and FiO2. And in the end, they found that if they lowered the tidal volume and and increased the amount of PEEP that was to kind of keep the lungs inflated and popped open, that they were able to save more lives that way. And that kind of was the initial event that kind of led to a lot of research that has kind of filtered down from the ICU to the emergency department, and then now it's spilling out into the EMS setting or the out-of-hospital setting.
And that definitely makes sense. Distending patients' lungs is never good, but why is using a pediatric BVM versus just using an adult BVM properly? Why is that better?
So the adult BVM's decades old. It came out in the 40s or 50s, if I remember correctly. And back then we thought, okay, patients need 10 to 15 milliliters per kilogram. So these tidal volumes that were needed were in the 700-800 all the way up to 1500 cc or milliliter range. And so the adult BVM was kind of geared towards that. And then since the ARDSNet and subsequent papers came out, we realized, we need to be in the 350 to 550, maybe 600 range. So we're now shooting for a smaller target, but the equipment that we're using was geared towards the much larger tidal volume. So it's really hard to use a big hammer to kind of cap in a very small nail. The way that I teach my paramedics is it's like hanging up a small picture frame nail with a sledgehammer. Sure, you can do it, but you're more likely to put a hole or scuff your wall or put a hole in your wall because you're using this big, heavy hammer. So it's really hard to be more finessed with a larger tidal volume based BVM like the adult BVM, and the pediatric BVM is more geared to be in that range of 350 to 550 if that's what we're shooting for.
Right. And everybody, when you're back at base or you're training in a class, using an adult BVM, it's a lot easier to stay controlled with your squeezing of the bag. But when you're doing it for real, everybody tends to just crush those bags and send pretty large volumes of air.
Yeah, we're starting to see the manufacturers scale back on the size of their adult BVMs because of this research. So the needle is starting to move towards the safer range, and they're redefining what they consider an adult BVM. So we're hopeful that they'll continue to make equipment for us that prevents us from doing harm to our patients.
I understand about like the ARDSnet, but there's so many other people that don't really fall into that that type of ventilation strategy. Is this something where this is a training problem that we need to retrain guys on how to use this effectively, or just train them, period, how to use it effectively? Or is this an equipment issue where we need smaller volume BVMs,
Correct. So I guess what we still need to decide on as, I guess, medicine as a whole is what is the initial tidal volume range that the generic person should go on, and who doesn't have any signs of any lung injury. And once we know for sure that, they need to have 6 milligrams or 6 milliliters per kilogram of ideal body weight, or 10 or 20, then we can start to hone in our equipment. It seems like we have the history of ventilation research has started in the already known to be injured lung, which was where ARDSnet came from. And they took people with confirmed acute respiratory distress syndrome up in the ICU on a ventilator, and then they made the change from the 12 per kilo down to 6 and just kind of saw what happened. And they saw that effect, that they said, look, we are killing less people with a lower tidal volume and a more aggressive use of PEEP. And then the ICU started to, really run with that idea. And then our emergency department around the country, we saw what they were doing up in the ICU, and we said, well, we're seeing sick people with sick lungs. Maybe we could start doing that care that's, quote unquote, upstairs care. We could start doing downstairs while they're either waiting for an ICU bed, or we don't even know if they're going to go to the ICU yet. If you're on a ventilator, you usually almost always go into the ICU. But we started to incorporate already on the known sick lungs when they're in the ED. And then we had some smart people say, well, if they aren't sick, their lungs, let's say we intubated them for a head injury, or because they're intoxicated, or some other cause, just a sepsis from a urinary tract infection or a leg infection, but their lungs look pristine, can we prevent the acute respiratory distress syndrome from even happening? And it seems like if we implement a lung protective ventilation strategy from the onset of positive pressure ventilation, we can delay, if not completely prevent, ventilator associated lung injury, or ventilator induced lung injury, VILI, ventilator induced lung injury, that would eventually lead to ARDS and then eventually morbidity and mortality. So it seems like going in the backwards direction, the 6 to 8 milliliters per kilogram of ideal body weight with an aggressive use of PEEP when available helps delay, if not prevent, ventilator-induced lung injury. And that's probably where the generic intubated or positive pressure ventilation patient should be getting started, and then we can go up or down from there.
Now, for an ARDS patient or a patient with some kind of lung injury, using these really low tidal volumes definitely makes sense to prevent, over distension, making the problem worse. But what about patients that do not have a intrinsic lung injury? So there's nothing wrong with their lungs, but I still need to ventilate them for whatever reason.
So we actually have done studies similar to that in the emergency department setting, and we found that if we take people with no known ventilator-induced lung injury or ARDS showing on their X-ray or CAT scan, and we start them on the lung protection strategy from the get-go, we can actually prevent or at least delay the onset of the harm of positive pressure ventilation. So it stands to reason that if we can not beat up the lungs with high tidal volumes and high pressures, that we can prevent the bad outcomes from happening, so that we're not having to do what the ARDS-MET paper was doing, which was taking people who already had the bad outcome and hoping to not have a death out of it. So now we're trying to, before you even get injured, we're trying to prevent the injury or prevent the death from lung damage from the ventilator.
So I guess what kind of lung damage were they creating?
So we're designed to breathe with negative inspiratory force. We're not meant to have positive pressure ventilation. So the lungs, when they receive a positive pressure breath, they get injured, at some level with positive pressure. It's just not natural for us to breathe that way. And so the lungs, every time they get ripped open from that collapsed atelectasis state, it can create a little bit of injury and a little bit of inflammation. And the more you do it, as well as the level at which you do it or the severity of it, both of those types of events, the frequency and the severity, can increase inflammation, which can lead to injury to the alveoli, can increase fluid collection, and then make the lungs stiffer and more difficult to open up and then ventilate through and oxygenate.
Right. So that's atelectotrauma, if I remember.
Yep. That's one version. Then you got barotrauma from the pressure, and you got volutrauma from the volume. So you can get injured in various ways, plus the injury from the start, whether it's blast lung or a gunshot wound or a fall or crush. So there's a lot of different ways the lungs can get injured.
So also reading your paper, you had mentioned a study where using a pediatric BVM, it was more difficult to maintain an SpO2 or a sufficient SpO2 without adding oxygen to it. I guess since you're using the pediatric BVM on patients, how do you overcome that?
My recommendation with the pediatric BVM for my EMS providers, my paramedics, and my EMTs is to have a PEEP valve on the pediatric BVM, so that way the lungs will stay opened up or stented open from the internal pressure at the end of expiration or exhalation. So if you think about like a balloon, we're not re-inflating the balloon every time and letting the lungs collapse down with atelectasis. What we're doing is we're inflating the balloon halfway and then just having small breaths in and out to cycle, to do air changes essentially, and that will help pull the CO2 out and push oxygen in. Now, I work in a civilian setting where oxygen is plenty, obviously pre-COVID, where we don't have to worry about oxygen being gobbled up by patients. But for providers where oxygen is limited, like a prolonged field care, it could be difficult to have good oxygenation with smaller tidal volumes. So we would have to kind of trial it on patients where we could keep the PEEP, but drop the FiO2 down to room air or some smaller amount that you guys are able to provide.
Okay. Is there another attachment that through the BVM I can be more aware of what type of volumes I'm pushing? So if I don't have a pediatric specific and then also have to bring on an adult sized, I could, with an adult size, just control my volumes that way.
Yes. So quick statement. I don't have any conflicts of interest in the product with any of the products I'm about to mention. But Zoll Monitor Company is in the process of releasing a product called Real BVM Health, I believe it's called, and it is supposed to be an inline volume meter to feedback through the monitor and tell you how much air you're putting in. So that way you can use an adult BVM. It just takes a lot more effort to not go over whatever limit you set. There's a company, I believe, out of France that has a standalone product that is an inline attachment that will give you feedback of your volumes. You can try to use pressure as a surrogate for volume with a manometer, and some BVMs have manometers attached to them and give you kind of a green, yellow, red. So essentially what you're doing is pressure-controlled ventilation and hoping that you don't over-distend the lungs with volume that way. So the product companies out there are seeing the need to give a volume feedback to the provider. We just need to keep going with that, either with aftermarket standalone products or with our ventilator or with our monitor companies that they're starting to do. Okay.
On top of issues as far as oxygenation, I have another issue as far as being in dysynchrony with my patient. I personally, I don't use paralytics, and generally I don't deeply sedate somebody, at least definitely not routinely. I know that's going to be an issue if I'm in dysynchrony with the patient, trying to breathe a lot less, give them a lot less volume than maybe they're wanting. They're outstripping my BVM. How can I overcome this?
It can be tough if you have an awake patient. I mean, it depends on the reason that you're providing positive pressure ventilation. If the person just has an airway injury and you can leave them with breathing on spontaneously, then you may have to consider that. But if they need positive pressure ventilation, but they're still lightly sedated, you may find them, showing signs of air hunger, and then it's a risk benefit ratio that you have to make right then and there of, do I provide deeper sedation and potentially use up my precious resource of sedatives and ketamine and other versions of that for this one patient, or do I elect to use an adult BVM, give them larger tidal volumes, but risk inducing a ventilator induced lung injury? I don't think that there's a one size fits all answer. It's one of those situations where with all of the evidence that you have available, you're going to have to kind of make that decision. So unfortunately, I can't give a perfect answer, but it will force you to say, which is the lesser harm in this situation.
So talking about, drugs, and we use ketamine. With ketamine, do you think I could put somebody or disassociate somebody strongly enough that they would be compliant with, much smaller tidal volumes?
I do. I mean, we've seen, if you give someone a 1 to 2 milligram per kilogram IV bolus of ketamine and put them in a RASS or Richmond agitation sedation score of like -4, -5, they're very tolerant of any painful procedure, including perceived air hunger from reduced tidal volume and increased PEEP. So I think if you were using a pediatric BVM and you were getting ventilator dysynchrony while someone was more awake, reducing their RAF score to a deeper, -3, -4, -5 with a higher dose of ketamine or any other sedatives that you have available, I think you will find that they are much more tolerant. It's a risk benefit, like with all things, it's a risk benefit ratio. You may get short-term gains, but they may be more difficult to wake up in the long term. It's harder to get a neuro assessment on someone who has a lot more sedatives on board. So I think, you have to make that decision. But I do believe if you needed to stop ventilator dysynchrony, giving more ketamine will get you that result.
Okay. just to try and pimp the expert a little bit more, what other things? So let's say I have a couple more grams of ketamine. I have 50 milligrams of midazolam left, and I have a patient that I need to sedate so that I can properly ventilate this person, and I expect to have to do this for the next 4 to 6 hours. What things are going to go through your head to make a decision? I'm going to deeply sedate them and just use this pediatric BVM, or I'm going to use the adult.
If you're expecting to be able to only have to do this for 4 to 6 hours, I think that it would be in the patient's best interest to have deeper sedation and lower tidal volumes in line with our best available evidence from hospital-based data, which would be the lung protective ventilation, more use of PEEP, less use of volume. Now, if you've got 4 to 6 days, then I think at that point you have to weigh the needs of the many over the needs of a few in that situation. And you may find that you're going to elect to use larger tidal volumes and hope that the lungs just don't get beaten up too severely.
Okay. Is there other things that I can do, I guess, other than just try to not blow them up too much, which is a pretty arbitrary thing to say? Anything else I can look for, since if I'm only have an adult BVM, to try and minimize the volumes?
Well, you can, if you're forced to use the adult BVM, you can try to limit the amount of air that goes in by restricting the amount of fingers that squeeze the BVM. I have a different paper that shows that if you pinch the BVM with just like a thumb and middle finger, just that single finger pinch, you average about 800 cc's of air as opposed to 1,000 plus if you do kind of the full hand grip. And so you can limit that. And then if you also instruct the person squeezing the BVM to just stop when they see chest rise, that will also limit the amount of air that goes in closer to the 500 to 600 range. Additionally, you can sit the person up if they're able to do so. That will help ventilate. That will help them aerate better because lungs weren't really designed to breathe laying flat. So kind of a whole package, a bundle of care, as you will help, even if you had to use the adult BVM, will help better ventilate the patient. And then if you can get a manometer, one of those pressure sensors, that will also help prevent over distension of the lungs.
Okay.
Does that answer?
Oh yeah.
That give you
absolutely. No, that's
okay.
Good tips. Because a lot of those are just advice that we've gotten from, our initial course. But we tend to forget that.
Yeah.
About lung recruitment maneuvers, how does that change with using a smaller BVM? Are we still able to do the recruitment maneuvers?
It's kind of dependent on the patient and what's going on inside their chest. And so if they already have stiff lungs, then you might be able to achieve pressures that open up the lungs. But if you've got a tall operator who has a large volume and the PEES BVM, and you don't have a PEEP valve, you probably won't achieve high PEEP or high mean airway pressure to stent all the lungs open. Now, if you can get a PEEP valve on and dial that into 20 or more, that plus the positive pressure breath, you might be able to get a couple of consecutive sequential breaths before the volume escapes out to where you can recruit, open everything up, and then re-recruit the lung.
You mentioned a PEEP of 20. That's probably the top end of our PEEP devices. Do you find that using a pediatric BVM, you have to use a higher number?
No, it depends on why you're ventilating the patient in the first place. Do they have a lung injury, or were they an aspiration event? Is this a post-cardiac arrest or a trauma versus they have, a head injury or they're intoxicated? So it just depends on the status of the lungs that they get. But I would say that outside of someone with known pulmonary edema, we generally aren't hitting PEEP above 10 unless they're morbidly obese or have a lot of weight on their chest and it's just kind of compressing downward, or they have some irritation, inflammation, or infection of the lung. Most patients do well with 5 to 10 of PEEP and a tidal volume in the 400 to 500 range, which is easier to do with the pediatric BVM. You're more likely to do it as opposed to try to do that kind of narrow range with the adult BVM. You can still do safe ventilation with the adult BVM. It's just a lot harder because it's at the very left end of the bell curve.
Right. Yeah, you have to pay attention.
Yep.
Yep. Do you find that with the pediatric BVM, as far as your rates to keep up with oxygenation, to keep up with your ventilation as far as end tidal CO2, do you find that those rates go up or stay the same?
So my EMS providers, they're using, high flow oxygen the entire time, 15 to 25 liters of oxygen. So the patients are well oxygenated, and we are not seeing hypoventilation and hypoxia unless they were already difficult to begin with, or they have, shock or some other extrinsic cause for hypoxia. But if it's a uncomplicated patient and they just need to, have their airway managed for whatever reason, the flow of oxygen that we're able to provide is more than enough. I'll be honest, I have not needed to ventilate anyone or have my providers ventilate anyone without oxygen or restrict down to 2, 3, 4 liters because of need to conserve. So your results or your mileage may vary if you can't provide high flow oxygen, and we don't have that data currently. We'd have to repeat my studies or versions of my study in the prolonged field care, either on animal data or just retrospectively kind of looking at observational data from actual patient events.
Right. Is there anything else you'd like our guys to know about using or at least considering to use a pediatric BVM as far as lower pressures and tidal volumes?
Yeah. The first thing is the BVM is actually, it's a ventilator. It's no different, or when you consider it, it is a mechanical ventilation device. It's just powered by someone's hand as opposed to a pump inside a machine. So you have to treat it with the same level of concern and respect that you would any kind of portable or stationary ventilator. And when you change your mentality about, it's just the BVM to, this is a ventilator, you're more apt to be cautious and really pay attention to the amount of air you're putting in. Now, obviously that's situational dependent to making sure that if you're in the middle of some kind of tactical field care or threat environment, you may not be able to provide pure attention on the BVM. But if you're in a situation that's low threat, really spending just kind of watching it and kind of feeling the amount of how the air is going in and making sure that you're not seeing excessive chest rise or doing a full squeeze. If you can, and you can use if you can use a pediatric BVM, then you'll find that the goal ventilation strategy that we want to do is more successful with a pediatric BVM. Hopefully, we can figure out a way to get you guys a volume meter or ability to feed back the volume that each breath that was delivered, so that you can see. And then you could be a little bit more open to any size BVM because you would just get I got 550, I got 520, I got whatever. But outside of the ability to see with each breath, I think you're more successful with a pediatric BVM and a PEEP valve than you would be trying to limit the amount of air you put in with the much larger adult BVM. It's just really hard to restrict, something that's capable of putting 1,500 in, but now you only want to put 400. It's really hard for a provider to just get 25% of what's capable versus, this is, 50 to 70% of what's capable with the pediatric BVM.
Right. Hey, thank you, Jeff. I really appreciate it.
Yeah, no problem. Just glad to help. Would love to continue to, work with you guys. And if anyone wants to collaborate on stuff in the future, feel free to reach out.
Oh, I'll definitely be hitting you up. That's it for today's podcast. Be sure to go to our website, www.prolongedfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy, it's waiting there for you.